Mihi nui kia koutou, and thank you so much for being with us today for our webinar. Let's start with a karakia. Whakarongo, whakarongo, whakarongo ake au ki te tangi a te tui, 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 tui a. Tui a I runga, tui a I raro, tui a I waho, tui a I roto, ka rongo te pō, ka rongo te au, ka au, ka au, ka awatea. Tihei, mauri ora. Ngā mihi nui kia koutou, tēnā koutou katoa, and welcome to our webinar. Thank you so much for joining us. No ingarangi me kōtirana o kutipuna, I tipu au I raro I te raukura o te Aotearoa I te pito o te Oni. So my ancestors were from England and Scotland, and I grew up under the feathers of Te Aotearoa in Petone, where I now still live. Ko Holly Walker, tōku ingoa, e mahi ana ahau ki Mahi Ārongo. So I'm Holly Walker, I'm an Associate Fellow at Mahi Ārongo, the Helen Clark Foundation. Nō reira, tēnā koutou, tēnā koutou, tēnā koutou katoa, and once again, welcome to you all. It's my pleasure to be hosting this webinar on perinatal and maternal mental health today. And I'm sure you've attended a million of these Zoom webinars by now, but just a few quick housekeeping points before we get started. So as our audience members, your cameras and microphones are all automatically off and will be off for the duration of the webinar. So you can make as much noise as you like and you don't have to worry about interrupting us. I think that's probably pertinent for some of you who may have small children. I think we might have a few in that category today. But that does not mean that you can't be an active participant in the webinar. In fact, we very much hope you will. And there are two ways that you can do this. So if you have a question for the panel, you can enter that into the Q&A function at the bottom of your screen. And even if you don't have a question of your own, do keep an eye on the Q&A function as we go, because there is an option in there where you can like other questions that you want to hear answered. And the ones that get the most likes kind of bump up to the top of the list and make it more likely that we'll get to them. So I'll be watching that Q&A and I'll be putting some of those questions to our panelists later on in the webinar. And the other way that you can participate is in the chat. So please feel free to mihi to us all in there, tell us who you are and where you are. You can talk to each other during the webinar. You can share relevant links if you like, just no commercial promotions, please. But feel free to have a free-flowing conversation in the chat function whilst the webinar is going on. The chat is also the place to put any technical queries, and our Communications and Outreach Director, Grace, will help you with those if she can. And Grace will be also dropping some links into relevant reports and reports written by our panelists in the chat, so you can download and read those at your leisure, including the report we're here to talk about today. But I will not be actively monitoring that chat, so please remember questions in the Q&A, chat in the chat. So if this is your first interaction with the Helen Clark Foundation, welcome. We're a think tank, a public policy think tank based at AUT and dedicated to the values that have underpinned the distinguished career of our patron, Helen Clark, our values of fairness, sustainability and democracy. We publish research on the big public policy challenges facing Aotearoa New Zealand and the world. We host events like this, and we advocate for our recommendations to be implemented. And we're funded by a mixture of formal partnerships, donations, grants, and individual memberships. So if you are a member, I'd like to give a special greeting and mihi to those of you who are. Thank you so much for your support. We literally could not do this without you, our members. I would also like to acknowledge 3 organisations for their support of our maternal and perinatal mental health project, and those organisations are the Tyndall Foundation, the Rata Foundation, and the new health agency Te Whatu Ora, the National Public Health Agency within Te Whatu Ora, so the part previously known as Te Herenga Hauora, or the Health Promotion Agency. So all 3 of those organisations have provided generous support that means we can not only publish our research on this topic, but also roll out a program of events and conversations like this. So we're very grateful to them. Now, this might sound a bit obvious, but just before we get started, I did want to flag a bit of a content warning on this topic. So if, like me, you are someone who has lived experience of perinatal distress, just please take care during the webinar. It's really awesome that you're here if you're in that category, thinking about how to change things for the better. But if you've had quite a fresh experience, possibly parts of this conversation might be a little bit challenging. So we will be discussing potentially triggering topics, including pregnancy loss, potentially birth trauma, breastfeeding, even suicide. So if at any point you just decide, actually, this is not for me right now, kei te pai. My own experience of perinatal distress was 8 years ago, and I certainly could not have had many conversations like this until quite recently. So please feel free to just drop out at any point if you need to. Even if your perinatal days are quite a long time ago, sometimes things can just unexpectedly get stirred up. So if any of that happens, just prioritize your own well-being and feel free to leave. And we've dropped some links in the chat there, I think, to a list of support organisations. So either if you find you need to, if you find yourself upset by the conversation, please feel free to reach out to any of those after the webinar. So with that said, I'd now like to introduce our amazing panel and give them a chance to mihi to you all as well. And I'll start with Amanda Malu. So Amanda, who is kaitahu, has been the Chief Executive of Whānau Awhina Plunket since 2016. And I think she's actually just about to finish in that role, so we're lucky to have her here today. And during Amanda's time at the helm at Whānau Awhina Plunket, she's led a transformational strategy for Plunket to become a fully equitable organisation. I'm sure she'll talk a little bit more about that with us during the webinar. And she also has an amazing whakapapa link back to Plunket through her great-great-grandmother, Mary Harper, who was one of its founding taua. So tēnā koe e Amanda.
Kia ora, Holly. Engaro o te kōtuku, o hui hui mai nei, tēnā koutou katoa. Kia Kelly, koutou ko Jacinta, ko Holly, tēnā koutou. Ki ngā manuhiri o te hui hopa, Zoom, Zui, tēnā koutou katoa. Ko wai au, ko hikaroaroa te mauka, ko waikawai te te awa, ko arai te uru te waka, ko puki te raki te marae, ko kati hui rapa te hapu, ko kaitahu te iwi, ko au te mokupuna o Mary Harper, ko au te mana hautu o Whānau Awhina, no, ko Amanda Malu tōku ingoa. Nō reira, tēnā koutou katoa. Hi everyone, fantastic to be invited to be a part of today's kōrero and to be in such esteemed company. And I'm really looking forward to the conversation and just want to acknowledge the Helen Clark Foundation for the great work in putting out this fabulous report. So ngā mihi kia koutou.
Kia ora, Amanda, thank you so much. Next, I'll introduce Kelly Feng. So Kelly has worked in the mental health, addiction and social sectors for more than a decade, and she's been National Director of Asian Family Services also since 2016. She's a registered social worker. She was a medical doctor in China before migrating to Aotearoa New Zealand in 2002. In 2020, Kelly co-authored a research report about the perinatal and maternal mental health experiences of Asian women in Tamaki Makaurau, Auckland. And she's passionate about advocating for more culturally appropriate services for the Asian community in mental health and in general in Aotearoa. Tēnā koe e Kelly.
Kia ora, and my name is Kelly Feng. Thank you again for inviting me to be part of the panelists together with Amanda and Jacinta, and really appreciate Helen Clark Foundation to have this opportunity to share our work as well and to have a diverse population perspective as well. Thank you, Holly, and thank you for all the audience. I see over 200, so really looking forward for the discussion and share the work and mahi here. Tēnā koutou katoa.
Kia ora, Kelly, thank you. And finally, Jacinta Fa'alili-Fidow is the founding director of Moana Research, now called Moana Connect, a research consultancy focused on evidence-based solutions to ensure that families have access to essential services and resources. Jacinta has extensive leadership experience in health research and public health and in Pacific wellbeing. She's got a Master's of Public Health and currently, I believe, working on her PhD as part of the Growing Up in New Zealand study, investigating resilience amongst Pacific families. And Jacinta is also the co-author with Mary Roberts of a 2021 report on the perinatal and maternal health needs of Pacific women. Tēnā koe, Jacinta.
Mahalo so for mo malang mama whaptaitere lava ya Holly Walker ma le Helen Clark Foundation mo le ne avano ya whape fo I Amanda ma Kelly o whaatasi mai le ne whanotanga. Kia ora koutou, ko Jacinta toko ingoa. It's a real privilege to be part of this webinar. Thank you so much for inviting me to share my thoughts, and I do look forward to attempting to reflect the voices of our Pacific families and communities, and to highlight some of the great points that were made in Holly's report. Thank you.
Well, kia ora, thank you all to our panel, and I'm really looking forward to your insights during today's webinar. We'll come back to our panel shortly, but before we do, I'm going to share a very brief presentation which will introduce Āhurutia Te Rito, It Takes a Village, so the report that we published earlier this year at the Helen Foundation as the sort of anchor for our perinatal and maternal mental health project. So excuse me while I just set up the screen share for that. Well, excuse me, I'm just trying to get my presenter view up at the same time. I'll just pause the sharing for a second. My apologies, this is not a problem that I have had before. Bear with me for just a moment. Okay, we'll just have to proceed. Apologies, I may not be able to see my notes as we're speaking, but allow me to introduce this report. So Āhurutia Te Rito, It Takes a Village, how better support for perinatal and maternal health could transform the future for whānau and communities in Aotearoa New Zealand. So just briefly about the name of the report. So I was very fortunate to have the opportunity to work with Dr. Hare Williams, who contributed to the naming of the report and took me through some of the meaning behind these kupu. And and it's quite beautiful. I won't do his words justice at all, but I'll do my best to explain a little bit of the meaning. So Āhurutia conveys something like preparing the way or creating a place of comfort and warmth in preparation, in the analogy that Dr. Williams uses, a mother bird feathering the nest for her young. So Āhurutia is a change of state. It conveys preparing a smooth and comfortable pathway. And Te Rito, of course, as this image suggests, is the new growth at the centre of the harakeke or the flax bush. So the new growth are supported by the matua, or the mature leaves that surround them, which are in turn supported by the kaumatua, or the outer leaves of the harakeke flax bush. So you can see why this is a very common and beautiful metaphor in Te Ao Māori for the way that intergenerational whānau support surrounds new life and new babies at the beginning of their life. So altogether, the name conveys preparing for the new generation and intergenerational support for the next generation. The question that we set out to answer with this report was essentially around what is contributing to poor mental health amongst new and expectant parents in Aotearoa New Zealand. So I had the experience of hearing in a previous role I had working for the Children's Commissioner, Sir Peter Gluckman, come to talk about some research that he was part of, medical international research, looking at the impact of maternal distress during pregnancy on babies' cognitive and development and long-term outcomes in life, and was kind of both shocked and somehow not surprised at the same time to learn that maternal mental health was almost the single biggest contributor or predictor of long-term health and wellbeing outcomes for babies. Shocked because if that's the case, we really should be doing so much better, but in some ways not surprised too, because it's quite intuitive. Actually, if we supported parents and mothers better at the beginning of children's lives, we perhaps would have very different outcomes. And we're often thinking about how to repair intergenerational well-being and focus on giving children the best possible start in life. And actually, in many ways, the answer is quite simple in terms of supporting birthing parents and mothers better. So the question, having had that seed planted, the question we set out to answer was really, what is it that's contributing to that stress, and how can we use public policy to remove it? And from that, we gleaned three key insights. So we looked at academic and medical and published academic research on this topic. We looked at the experiences of people who have lived through perinatal distress, and we looked at the expertise of community-led and kaupapa Māori service providers and organisations, clinicians, midwives, doctors who have a lot of interface with communities, and together from those sources we put together this research. So the first insight is really that actually, if we get this right, it could be very transformational for our whānau communities. Perinatal distress causes huge suffering for parents. It can have lifelong implications for babies, both through that biological transfer I talked about before of the stress response in the body during pregnancy, but also after birth in terms of the impact it can have on parents' communication with their babies, with their ability to bond effectively, with parent-child attachment, mood, how likely parents are to read and sing and speak to their babies. All of these things can be made more difficult by perinatal distress in the family, and the combined result can essentially lock an intergenerational disadvantage for that family. When we're talking about the perinatal period, we're talking about the period from pregnancy until the baby's first birthday, except when we talk about suicide statistics, when the cutoff point for what is thought of as the perinatal period in those statistics is 6 weeks post-birth. So the key takeaway from that insight really is that the combined impacts of these things are very significant, but that responsibility should not sit with the individual, but the causes are systemic and so are the solutions. And that leads us into insight 2, which is that this is very widespread, it's complex, and it is systemic in our society. So up to half of new parents actually are thought to experience symptoms of depression or anxiety. The data is not very good. We don't collect very robust data on this, but when we combine the estimates of those who are thought to meet the clinical definition of those conditions with those who are thought to experience symptoms that don't quite meet the clinical threshold, but nevertheless are still quite significant and can have an impairing effect in their lives. When we put those two estimates together, almost 50% of new parents are thought to experience some form of perinatal distress. So that's a lot of parents doing it tough. It really can affect anybody, but there are some groups who are at greater risk, and they include Māori, Pacific and Asian women. So you can see perhaps why we have some of the panelists that we have here today. All three of those groups are thought to be at greater risk, as well as disabled parents, LGBTQI+ whānau, very young parents for whom the pregnancy is unexpected, and where there are the presence of other forms of systemic disadvantage, including violence, low income, poor housing, food insecurity. All of these things interact to create very challenging situations for many families. The third insight is that the right support at the right time is really the key to unlocking this problem. So what that support actually is and looks like will be different for every family, because it's very individual to what someone will need at a particular time. But whatever form it takes, having access to it and knowing that you have access to support and knowing that there's someone who could help you if you needed it is the key protective factor for perinatal and maternal mental health. It works best when it comes from a source that parents already know and trust, which is why it's so important to support community-led, kaupapa Māori, culturally appropriate services. And when it's available, that early support can largely prevent the need to access more specialist treatment, because it can sort of stop the cycle of worsening mental health early on. But if things do get very bad, if someone does become very unwell, at the moment, it's very difficult to access specialist perinatal mental health support. It's inadequate, it's uneven, and according to the DHBs, in their own estimation, may not be equitable in its delivery. So we have quite a big challenge that we need to face. I won't spend much time now talking about the recommendations, but you're welcome to download the report and read them. But essentially, our focus is on the policy solutions. So the types of things that we're talking about in the recommendations is finding ways to alleviate those stresses for parents, make it easier for parents and their whānau to support them. That's things like sufficient income, adequate housing, big structural conditions, removing the things that are making it quite so challenging during this really important time of life. Access to continuous holistic maternity care, supportive birth environments and tailored assistance is really important. As I've said, so is community-led and kaupapa Māori and culturally appropriate services. Making sure everybody knows how to recognise the early signs of distress, making sure that there's access to practical support when it's required, that when services are needed, they are available quickly and they are appropriate, and that when people become very unwell, they need immediate access to specialist support. So my apologies, I had a much more nuanced way of describing all of those things, which I have had to abandon, not being able to access my notes, but that gives you at least a brief overview of the content of the report. So I'll finish sharing that now and look forward to coming to our panel. So I thought, those insights I've just outlined from our research are quite general. They're taken at the population level, looking at the experience across all of Aotearoa New Zealand. But as noted, some groups are both at particular risk of experiencing perinatal distress, but also may require different types of responses and interventions. So I want to come to you first, Jacinta, and ask you, from your research that Moana Research has undertaken into the experiences of the perinatal mental health of Pacific women, what are the things that you would add to those sort of general insights that are of particular significance for Pacifica Ainga?
Thank you, Holly. I do want to acknowledge the report and just how it gave a really good overview, and really, while it didn't deep dive into some of the issues that we wanted, it still kind of touched on a lot of key aspects, particularly around thinking about some of the cultural constructs of caring and of pregnancy and so on. I do want to acknowledge the resonance with Te Ao Māori. There are definitely elements that are unique to Te Ao Māori that were touched on in the report, and particularly our belief in the spiritual importance too of pregnancy and birthing and babies. They will certainly align. And for Pacific, when a woman is pregnant, there's almost a sacredness that's afforded the mom. She receives special treatment, afforded special care from everyone around them in the family. And in fact, when I think about Pacific cultures, we're often accused of being too patriarchal. But when it comes to pregnancy and raising children, this is one domain where a lot more attention is given to the mother. And there are spiritual connotations stemming from both cultural and religious beliefs. Children are certainly seen to be the present manifestation of a long ancestral lineage. They have connections to not just their living family, but, our ancestors. They're also, in terms of religious beliefs, they're seen as a blessing from God. So pregnancy itself, and motherhood has a certain, connotation there around being from God. And so on the one hand, these core beliefs really determine this nuanced way in which we treat mothers and women pregnant women. But on the other hand, there's a lot of current societal pressures on women and families that's just not conducive to enabling these core belief systems to play out. And so we can be accused of over-romanticizing these beliefs. But in fact, the shifts in the societal expectations on mothers today, they've shifted considerably, and they're much more aligned to, I guess, these capitalist societies that we live in and the way we need to live just to survive. And so I guess when I think about perinatal mental health, I do have to step back and consider, you know, from a Pacific viewpoint, all of these other contextual things that can impact on the way we hold that responsibility as a mother and as a carer, as well as just as an individual, as a human being that has a right to health and wellness. Having worked in the Growing Up in New Zealand study, we did see that Pacific women during pregnancy had the lowest rates of diagnosed depression by a clinician, but when they applied the EPDS tool, Pacific women displayed the highest rates of depression symptoms right across compared to other ethnic groups. And so, you know, we will conclude from that there's significant underreporting amongst our mothers, and there's a lot of women who are no doubt suffering alone, and who firstly would require that extra help to help them make sense and understand that what they're experiencing and feeling is not related to them being an inadequate mother first, and that there are actually causal pathways that have no bearing on something they've done or haven't done. But not only are they experiencing these direct symptoms of depression and anxiety, it's mixed in with the guilt and shame that comes from them not meeting their obligations to their family and the communities they work and so on. So again, with the societal expectations, not to mention family expectations, these do create this reinforcing environment to just compound all these issues. The other thing that I was thinking of too is that there's also a level of framing of depression that we do that as a measurable construct that doesn't quite align with the way that Pacific women perceive our world and our day-to-day. So some of our Pacific mental health clinicians are probably so much better at identifying those who are at risk, you know, simply because we have this better understanding of some of the triggers and some of those expectations, you know, across different settings that may make us much more vulnerable to depression and anxieties, and also thinking that, you know, we should do better at identifying how we do pick up some of these symptoms among our Pacific communities. I've got a lot more to say, but I'm just conscious that I've said too much already. I wasn't sure of my time frame, but coming back to the report, Sarah, yes, you did want me to talk about the perinatal mental health report. That was us looking at the acceptability of current mental health services. And so we spoke to mothers, but we also spoke to fathers, and we also spoke to grandparents. So again, recognizing that whole holistic approach, that village. And so what we found that we missed many opportunities for picking up, you know, mothers who were in perinatal distress. And so sometimes it was because of trust issues. So trust, we've put in this rubric as almost a cornerstone of the way that we should be thinking about acceptable systems, but that's often reinforced by the way we deliver them. And, you know, trust can be reinforced if we make sure that the systems are responsive to our Pacific families, that can then, word gets out, and that increases, you know, more trust. And so for some of them, though, it wasn't for lack of sharing. So we're assuming that they don't want to share, but when they do share, there were comments that were about feeling dismissed almost, or there was a bit of gaslighting, like, yes, but then there was no follow-up, no referrals. So, you know, there's clearly some sort of miscommunication type, you know, engaging and understanding thing going on there. So I might just hand it over at this point. Thank you.
Yeah, kia ora, Jacinta. So many amazing insights in there, and I'm sure we'll be able to draw on some of those threads a little more in the discussion. I'm really struck by that gap between symptoms and diagnosis of depression, and I suppose the idea that that big sort of capital D depression and what that means generally and in specific cultural contexts being a bit of a barrier for actually identifying where support is required, as well as lots of other insights in what you've said there. So thank you for that. We might come back to some of those things. Kelly, I'd like to come to you next now. You've done similar research looking specifically at the experiences of Asian women, and I imagine some of those resonances will be similar and some might be quite different from what Jacinta and her team discovered. So please, could you tell us a little bit about some of the key findings of your research?
Yeah, thank you, Holly. Just want to, before I start with the research, some of the key findings, just want to acknowledge Dr. Elsie Ho and Dr. Ingrid Wang as another two author of this research. And also our research was contracted by Northern Region District Health Board as well in 2021. So that was the time frame. So we were looking at this kind of research, what other factors drives Asian women to have a low access rates for maternal mental health services, and identify some actions to improve the access of maternal mental health as well. I think at the highlight, I'm not going to detail of the methodologies and all that. So the key challenge for a lot of Asian women, and again, before I talk about Asian, and Asian is already a very diverse population, over 34 ethnic groups identified within Asian. So in this research, we had covered Chinese and Japanese, and Indian and Korean, and one refugee background as well. So we couldn't, cover everyone, but it's like a majority of the representative here. So the key cultural challenge is relevant to Asian women's traditional role as a homemaker and mothers. Hence, compare with women from a more individualist cultural background, Asian women tend to feel like huge responsibilities during that period of time. Everything go wrong with the baby, and that maybe, the mother has to put the baby first in front of her own needs. So that's a kind of a lot of unseen kind of expectation already there. And Asian women's cultural background kind of leads that challenge within the family. And even though some of the mothers are expecting a lot of extra support, like, our Pacifics, Jacinta was saying, like in that time is a special time. And as a migrant woman, there's a lot of support normally they could access in their back country are not probably going to have it. Well, we even in the last 3 years, we had a COVID. Normally some extended family would come to support with extra hands and providing a special food dietary requirement after giving birth. But all those are become really challenging as a migrant new mom. So that's have been putting a lot of challenge literally along of some within the culture challenge as well. So that has been adding some extra pressure. We know that's again, the lack of understanding of maternal mental health and mental health is really huge stigma attached with you don't want to be labeled as mental illness or depression or any of the name. So that's why we found the help-seeking behavior are really low. Like people don't want to admit they're mad, like they got mental health issues as such to give that heads. So, and also lack of understanding of mental health system in general is another barrier for accessing services as well. And another thing we identify big, apart from stigma and mental health issues, is a discrimination language barrier, not knowing certain things are in place to support them, even psychological interventions are available and certain services available. So they really have a poor understanding around those support system in the society and health sector as well. So that's quite a significant just the factors, but again, to have a lack of awareness of New Zealand's service, but also the Western model that when they receive the service, even there's quite a bit of conflicts of even how you co-sleep or how you breastfeeding your baby. There's a lot of things that are quite conflict with the New Zealand Western model, so they tend to kind of not be quite trusted the system to speak out to what they actually practice within the culture to keep that bonding of mom and baby relationship. So that's another barrier we found is quite a significant within some of the new mothers as well. And systematic barrier of not really having, interpreters in place. A lot of women can speak English, but again, when it comes to the health and kind of terminologies, it quite challenging for them to understand the whole picture, probably partially, but they are probably too shy to ask, because then they will be again putting shame on themselves and felt discriminated as well. So again, that's another challenge. So there's a more systematic challenge as well, because the hospital, how it runs, and even the food, and challenging with the aircon on, because a lot of even given myself as a Chinese, the aircon is quite cold, and you don't want to have that blow on your head when you're just given birth. You don't have a cold showers. So some of the really practical stuff is not really aligned with some of the culture as well. So there's quite a number of things that are challenging for Asian women. But again, we found something we have after this research, some recommendations. So we really think the literacy of mental health issues that need to be promoted widely in different language and different culture, and to really raising that awareness, like under the public health scheme probably, and to be kind of a reduce stigma and discrimination, to almost like it's okay to seek help, and it's okay to be vulnerable at a time, because that's a time you need extra help. And we also found, like, involving families, fathers, and with the whole programs, that to know is, some of the Asian cultures, the fathers not giving a lot of help because they think that's not their role. But again, we'll probably have some kind of encouragement of those programs will be helping to get some extra support from the family, even their extended family from overseas can't come. And the other things we were suggesting is develop a more culturally appropriate resource and destigmatize mental illness, and promote early help seeking materials that can be easy accessed from the community as well, and improve early interventions in the primary level, so the the midwives can screen, and to have that resource in place, and psychological intervention and culturally and linguistic appropriate services available as well. And also to grow the workforce of ethnic who speak different language, and refer to different services that are at the early stage as possible, not wait, put a long waiting list. So that could be some of the improvement. And also cultural competency training to all mainstream staff, and to be more aware what other things are challenging for women in this period of time, and to pick some cues, and to be aware, and to refer to cultural support services when they're available. And of course, this is first research for a long time, that we need more research, and to change the system, and making more policy strategies to make it better for our future moms and babies. Yeah, thank you.
Kia ora, thank you, Kelly. I was very struck reading your research and then the conversation that you and I had a few months back on this topic, as well as reading Jacinta's, and reading some of the sources that inform the focus on Māori cultural practices around pregnancy and birth. Many cultures have over many years developed really robust cultural practices around pregnancy and birth that are all about taking care of the birthing parent, the mother, and the baby during this important time, and surrounding them with collective support. And those practices take very different forms in different places, but they often involve eating of special foods, intergenerational care around the mother and the baby, and those things, now with what we have an understanding of in our kind of scientific and medical research, make a huge amount of sense for the outcomes, mental health and physiological outcomes of mother and baby at that time. And yet the way that we live, certainly in a kind of modern Western society, is very often very alienating from those cultural practices. And it's interesting to reflect on often quite simple changes in a hospital setting, for example, that could make it easier for someone to be able to access or to carry out those cultural practices that are actually quite big barriers at the moment. So really useful perspective, I think. Amanda, I'd like to come to you now. You know, Whānau Awhina Plunket is an organisation that has a huge amount of reach and contact with whānau ainga families every day, as a major well-trailed tamariki ora provider and a national institution really, who see many of our families at this stage of their lives. And so both has the opportunity, I guess, to really see quite in an immediate way what the reality is like for many families, but also be a key conduit for identifying potential distress, helping to connect people to support, knowing whether that support is in fact available when they get referred. Like to come to you now for perhaps some insights from your perspective at the helm of Plunket about what's really going on for families across the motu.
Kia ora, Holly. Look, listening to Kelly and Jacinta, completely tautoko what they're saying, and that would resonate with so many of our staff who are experiencing, and seeing that for themselves day in and day out. We have the privilege really at Whānau Awhina Plunket of being invited into people's homes, and speaking with them in their own environment, and certainly our experience would completely support the findings of your report, that there are a significant number of mums and parents who are experiencing perinatal anxiety and distress, and in some cases some quite serious mental health issues. And I think for my staff, for our kaimahi who are working with whānau, probably their biggest concern is where do we send, where do we refer these mums for support, for help? And at the moment there is definitely a demand that's not being met by the supply out there, and I know that weighs heavily on our nurses particularly, who will often forego the rest of their appointments for a day to sit with a mum in distress and work with her on options and try to find connections and support for her in the community. So it is tough out there for mums, and I think for all of the reasons that everyone has spoken about before, the very westernized view that dominates about parenting and birth and the expectations that sit on the shoulders of our mama are huge, and I think there are answers to be found in our, in the pūrākau and ori and, traditional Māori parenting, approaches to parenting, but also across all cultures. And I think there's some hope to be found there, but the funding needs to be flowing in that direction in order to provide those sorts of supports. I think, that would be my single biggest insight really is, we really need a fundamental shift in how we think about the way we support parents and mothers in particularly, but not only mums, in their parenting journey, their birth journey today, in a way that sets them up, in the best possible way for the future. All the scientific evidence, supports it. Everything that, my nurses and kaiawhina will tell me supports it. And we really just need the dollars to start flowing in that direction so that we can see the services being stood up and supported for our whānau. So perfect timing for this report to be coming out. It's a very hot topic of conversation, and I know later on we're going to talk a little bit about the impacts of COVID and the pandemic and what that has had on our mamas. So I won't go there, other than to, I guess, foreshadow that it has had a significant impact on our mamas. So tautoko, and looking forward to the rest of the discussion.
Kia ora, Amanda. Unbelievably, we don't have actually all that much time left, but I think we've learned a huge amount from the contributions so far. So I'm going to come now to the questions from the audience to make sure we can get through as many of those as possible. And perhaps we can do these in a kind of rapid fire way so that we can cover off some of the key points. Looking at the questions that are coming through, one very strong theme, not surprisingly, is about the role of midwives and how incredibly important they are in the ecosystem of the perinatal period, and that we're very lucky in many ways to have this model of continuous maternity care in Aotearoa New Zealand. But of course, major issues, workforce issues, burnout issues, funding issues, access issues. So I'll roll a few questions together into one because there are quite a few here on that theme. But I'd love to get a quick comment from each of you about, I suppose, what's needed right now. And I think I know part of the answer. You've just given us, Amanda. It's about money. But, you know, how can we support midwives who do such a crucial function in this space? Any one of you who wants to pick that one up first, please go for it.
I'll just start with saying that we adore our Pasifika midwives. We work very closely with Pasifika midwives Aotearoa, and we had been working out of the Ngaha Mangere Birthing Centre for a while before we moved into our office, and they play a very crucial role in ensuring the that we can respond to perinatal mental health. I will sound a little bit contentious in saying that they are not the most significant solution to how we are going to solve this in the long run. And so while I think they play a very important role in helping to identify systems and symptoms and helping to respond to them and making sure we link them up to the right services and support, that role as a conduit can still fall short if the service they're referring our families to also falls short of responding appropriately to our families. So certainly having a role in being able to identify and assess and respond to and refer, but I don't think we're always relying on our midwives to solve every pregnancy issue and every infancy issue. So I just want to say that really quickly.
Yeah, kia ora for that, Jacinta. Kelly, or
if I could jump in, I mean, I'm not surprised to see that being a strong theme in the questions. There's a chronic shortage, of midwives, and it's a serious concern for our country. So I absolutely hear and support that call to make sure that we have the services available for our mamas. I think, almost sort of touching on your point, Jacinta, I think there's a bigger systemic issue at play here too, that that we really need to integrate and join up all of these services in a much better way, and so that it isn't all falling on the shoulders of midwives to solve all problems, and connecting our services and our referral pathways in a much more seamless way, so that parents are able to navigate that system smoothly. And I know for a lot of parents the tension point is around the transition from a midwife to a tamariki ora or whānau, well child provider such as ourselves, and just focusing on some of those little system issues could make a huge difference. You're not going to have that gap appearing between the kind of service that someone gets from a midwife and that they then receive from a well child tamariki ora provider. So I think there's a real, there's definitely a workforce issue right across the primary care, and there's also a systemic issue around that, systems and processes that are just disjointed.
Just quickly, I think, definitely we need to support the workforce development, and there's a cultural competence training, maybe you need to provide it, but again, like other said, we can't only solely rely on them, and we need to have some kind of innovation thinking. I'm just thinking, there's a lot of mental health, well-being kind of budget being put into the system, but again, what can we give the power of, the midwife maybe holding some flexible funds to support certain practical support at the time they need it, the mom need it. The other thing I want to emphasize is even for sustainable kind of a consistency, interpreting service are not there for people, accessing, mainstream midwife or other well-being services. They can't really have an interpreter at the time they need it. That's another big challenge as well. So hopefully the government can probably put some consistent funding for supporting those services to break the language barrier first.
Oh, thank you, everybody. I just want to address a theme I'm seeing in a couple of other questions around Māori-specific research too, and I'll drop a few links in the chat as we go. So Joanne Rama has asked, why is there no Māori-specific research on maternal suicide and no research on the impact of culturally competent care for wahine Māori? It's a great question. I don't think it's actually true that there's no specific research on those things, so I'll put some links in where I can. And I suppose I do want to address the fact that on our panel today, while Amanda herself is Māori, of course, she's not here representing a kaupapa Māori organisation or the views of all Māori. So we do, it's certainly absolutely really important to acknowledge the particular cultural context for Māori in Aotearoa New Zealand, and the fact that along with Asian women and Pacifica women, which again are really complex groups in their own right as well, Māori have a particular experience of this issue. In our report, we've tried to highlight and kind of give priority to Te Ao Māori as much as possible through the written report, which is partly why the focus is slightly different for today's webinar, because we did not give as much focus to the experiences of Asian or Pacific women in the written report, for example. So I do recommend taking a look at the longer report, and I'll share a couple of links to other research, not ours, on the experience of Māori women as well. And just also wanted to say one of our other planned actions in this program of work that we're doing is hosting a roundtable event at Parliament on the 20th of September on this topic, at which we plan to have a very strong focus on Te Ao Māori experiences and solutions. So just wanted to address that. I can understand why it might look like a gap, and it's certainly an area that needs major priority, but is also not one that we're unaware of on the panel here. So thank you for raising that really important question. Another question that's been quite popular and I think is pertinent is around, so Kayla Newman has said, it takes a village, and our support system, particularly our partners. So how do you think we can get our men more involved and educated about women's reproductive health? And I would add to that too about perinatal distress and how to recognise signs of it, how to support a partner who may be experiencing it. And I suppose how to recognise it in themselves as well, because it is an issue that touches on men and non-birthing parents too. So I'm interested in reflections from the panel on this question of how to involve the men in our families more in this issue.
Just thinking about the research that we did when we talked to fathers, and interestingly, when we spoke to the mothers about the fathers, some of the mothers actually talked about picking up symptoms in the fathers and in their partners. And so I think firstly too, we have to recognise that when we're talking about perinatal mental health, that it is also amongst the dads of, who are also parenting. And I think, that was highlighted simply because while the dads were certainly talking about how they want to do more, and they want to talk about it more with their peers, with other dads, there was a strong sense that perhaps we're focusing a lot on the mental health of mothers and not enough on the mental health of fathers. So that's something I just want to say up front. But I do think that there's certainly a movement now towards dads firstly just being able to express themselves a lot more in this area of pregnancy and parenting. And I'll talk about, the Pacific context here, and that it's often in the domain of mothers only, grandmothers, aunties, older sisters, that sort of thing. And dads usually were the ones who ran off and did the cooking and then came back. And so I think, over time we've learned, particularly, this is something that we love and we want to embrace more of, is dads having a much more active role in the role of parenting, but I think a lot of that has to do with increasing the connections that our dads have to support, increasing the connections that they have with other dads, and certainly increasing the connections in the way they communicate with each other in caring for a baby. Again, I want to give the others a chance, but those are just my initial thoughts.
Thank you. I think I mentioned that in our research, we also have one of the recommendations. We want to create that father program and to kind of normalize, what other things you do self-care and also support the mom and baby at the time as well. So certainly I think, culturally and linguistic appropriate public health messaging and promote that. How can they, be aware what's going on with the young mom and the pressure on the family at the same time and celebrate a new baby, but how do they look after the young one, and parenting together is very key. We haven't got a lot of material right now, so we need those things to be developed.
Yeah, and I would really just add that, there's some policy solutions here as well, potentially around the, extension of paid parental leave and the, providing families with the ability for both parents, and whether that's a mother and a father or, whatever formation is able to, to create opportunity for both parents to be more actively involved in those early years. And again, I think we're really we're playing a bit of catch up there. And again, we're applying such Western kind of models to our thinking. And I just come back to the opportunity that exists to look into, Te Ao Māori or, Te Ao Pasifika or, other cultures, to see you don't have to look far to see, that raising children was a responsibility of a whole community, and and yet our policy settings don't necessarily support that. So I think there's a real opportunity in terms of some of the findings of the report and what the evidence is telling us to really push harder on some of those things.
Thank you all. I'd like to, we're going to need to wrap up now, and I apologise to those who've asked many brilliant questions that we haven't got to, but perhaps we can touch on some of the themes and some of them in our final answers here, because before I sort of close things off, it's great that our conversations sort of migrated to this policy place, because that's where I'd like us to finish. As you know, we've just had a major transformation in our health system. We now have the new health agency, Te Whatu Ora, that has come into being on the 1st of July, along with the new Māori Health Authority as well. And I think there is a genuine intention in these reforms of taking a more holistic view of health and well-being, of taking a life course approach, looking across these key moments in a person's life when particular attention, prevention, resources required, and pregnancy and birth is certainly one of those, and to taking a more comprehensive and better evidenced approach to mental health as well. So there's a real potential, I think, in the changes we're experiencing at the moment for this issue to be prioritised better. But I guess we have to really make sure that we get that right. So I'd like to ask each of you quickly what you're sort of most excited about in terms of opportunities that this change provides, and perhaps what you're most concerned about in terms of your worry if these opportunities are not taken. And just to put some prompts in for you, looking at some of the themes coming through in the questions, people are interested in things like the connections with other policy areas, MSD, housing, education, oranga tamariki. I'm interested in the community sector and how we connect the community organisations into this space more comprehensively. People are interested in access to services. It's all very well to refer people to services, but if they're not there, then it's not very helpful. So anything that you kind of want to comment on in that wider policy space as we close off, come around to each of our panelists quickly to do that. Kelly, would you like to go first?
Well, thank you. I think that's a great question. I think I would say we definitely need a strategy and policy level to address a more holistic approach, because nothing standalone. Like I think even for prenatal mental health issue, there wouldn't be, depressed if they have all the support in place, and lack of, for example, they struggling with finance or housing, or they got domestic violence issues in the family or other issues, social factors. So we really need to look at early intervention, public health, clear message, and pick up from the midwife, GPs, and to provide that culturally and linguistic appropriate support. So that holistic approach for women's health is definitely need to be considered. And like we need to remove all the barriers of cross-government agencies, because I don't believe like one person will all ever have a one issue, and to refer to 10 agencies with 10 different issues is not practical. And like Whānau Ora, you have to have a wraparound service for the family, so they don't need to be dropped in between referrals. And so that need to be addressed urgently. And if it's not addressed, I think we are talking about women and young baby. That's a generation issue. So if we want to fix the system, that we get to start early as possible from the baby. Thank you.
Thanks, Kelly. Jacinta?
I guess COVID really highlighted that for our Pacific communities, we do have all the answers when it comes to being able to build up our communities, uplift, and also to work together. And I hope that we can do that with a lot of these issues that for a lot of our Pacific leaders have been advocating for a long, long time. I mean, it's great to know that mainstream are now embracing aspects of, being holistic care and well-being, but a lot of this was advocated for at a time when it was seen as quack science and airy-fairy. So, for us, it's about trusting our communities and our families to come up with a lot of great initiatives that I know that have already started, but can just be undermined if we just stop funding them, or if we just stop. I think we've got to leverage off a lot of the momentum that's been built there. And particularly when we're talking about perinatal mental health, all of those societal and structural issues that we've been talking about, it's great to see that through COVID, a lot of our sectors are working together, a lot more our providers are working together, but hopefully we can move closer and accept that for some of our communities, they've really stepped up to be health promoters, health champions as well. And they've been actively participating in the process of health and wellbeing. The thing that there are a lot of things I'm concerned about, but I guess one of those is certainly the long-term effects of COVID, pandemic generation. I think it's important that we can respond to some of the things that are coming out. However, I also want to highlight that we shouldn't miss the opportunity to pick up on some of the positives that have also come out. And I know we like to use the term resilience, but it goes deeper than that. There are things that our families and communities do that just aren't picked up by data. So we're always looking at a deficit, where instead we should be looking at better ways of reflecting some of these core strengths and supports that we have in our communities. And I'll leave it at that. Thank you so much for this opportunity.
Kia ora, Jacinta, thank you. And Amanda?
Well, again, so much as I agree with everything that has been said. I think for me, what I'm most hopeful about in the health reforms is the creation of Te Aka Whaiora, the Māori Health Authority, and the focus that that organisation can bring on the Te Ao Māori, solutions that already exist, and I have a strong hope that there will be really serious accountability, placed on funders to make sure that there is funding going into those sorts of services. I think alongside that, the new role of the iwi Māori partnership boards in the health system gives some real heft to to community-led solutions. And I think that's a phrase everyone uses all the time, but actually how often are we seeing it really happen, or are we seeing the funding actually reach that point? I know I talked briefly about what we're seeing with COVID, and we've seen the impact of mums who have given birth and spent the early months of their child's life in a lockdown situation. Auckland spent 4 months in lockdown last year, and the impact for mums is they haven't had that community connection that is so important, that peer-to-peer support, just basic things like that, being able to support and community agencies to really develop that. And NGOs, I do have to put a shout out for NGOs in the health system. We often carry a burden far greater than we're funded to carry, and that's not just, this is not something unique to Whānau Awhina Plunket at all. And I think that's probably one of my concerns about the new health reforms is, there's so much going on that these sort of NGO expectations are huge, and the funding and support for NGOs isn't great enough. And I know we're not the only organisation selling the family silver to keep the lights on. So I think that's probably my concern, is that it's such a huge change that you won't get the focus you need on some of these really key issues, and a focused strategy on perinatal mental health, for example, actually to be able to hold our funders and decision makers to account for addressing these issues. So yeah, I'm equal parts hopeful and concerned, I think, going into the rollout of the reforms.
Well, yes, thank you. That's a great note on which to finish, and a bit of a rallying cry, I think, for all of us who have an interest in this topic, to continue to make sure that it is as visible as possible while important decisions are being made about the future direction of not only the health system, but of the wider system of interconnected services and supports, and most importantly, community support, because that's, you know, as many services as there are formal services for people to access, often it's just the people they know, the people that they see every day, who provide that key support that is such a protective factor. So I think the challenge is not only about policy and service provision, but also about making sure everybody in Aotearoa New Zealand has what they need in terms of income, adequate housing, time to be able to support those in their lives who may also be parenting young children or in that perinatal period themselves. So thank you all. Thank you to our panelists very much for all of those incredible pieces of insight and wisdom. I can see that the chat has been absolutely just really very full of amazing comments, links to resources, incredible resource in that chat there. So we will leave the chat, we'll leave the webinar open for a few minutes after we finish up, just so people can have time to go through and copy down any resources and links that they're interested in. As you can see, we've gone over time. We could have talked for much, much longer about this. So I hope that you will continue the discussion in several ways. You continue the discussion with us at the Helen Clark Foundation. You can download the report. You can get in touch via our website if you'd like to talk more with me about this topic. There's a link somewhere in the chat. There's a link to our website, but also you can just email me. I'll pop that in as well in a second with each other. So as I said, we'll leave the webinar open for a couple of minutes so you can copy down any names of people you want to connect with more after this, or links that you want to follow up. In your mahi, if you work in a related field, if there are insights from this conversation, from our report, from Moana Connect or Asian Family Services Research, from Whānau Awhina Plunket's work, you know, please get in touch and also think about how these insights can apply in your context and in your daily life. So if you are a parent who is experiencing this right now, kia kaha, please know that you are not alone. As I mentioned earlier, there's a list of support organisations in the chat, or if you don't have time to copy that down, that same list is in the back cover of our report, so you can access it that way. If there are pregnant people or new parents in your life, perhaps think about ways that you might be able to assist them with the right support that they need. And remember the golden rules. Always bring food, never give unsolicited advice, always do the dishes. But perhaps most importantly, I think we need to be thinking about how we can influence system level change to improve perinatal and maternal mental health, not just for the people in your own lives, but across the whole of Aotearoa. So that's things like contacting your local MP, submitting next time Parliament is considering a relevant law or policy change, putting this issue on your work program if you're in a government agency with a related interest, thinking about the links with your work. All of these things make a huge difference. So I'd like to finish by extending a huge mihi and thanks once again to our panellists, Jacinta, Kelly and Amanda, for giving up their time and sharing their incredible expertise and insights. You can tell we only just scratched the surface. There's so much more in those reports and in their organisational knowledge. Huge thanks again to our supporters, the Tyndall Foundation, the Rata Foundation and Te Whatu Ora, Te Herenga Hauora. And finally, if you're not already a member of the Helen Clark Foundation, please do consider joining. There should be a link in the chat very soon or about now. As well as supporting work like this, members get early access to our reports and exclusive invitations to members only events, like one next week actually that we're hosting, very different topic, with Chatham House International webinar about the war in Ukraine, which will be hosted by our patron Helen Clark. And there's also a members only newsletter that you can access. So thank you so much again for your interest in this topic. As I said, our next event is a roundtable event at Parliament in September, where we're really hoping to connect relevant ministers and government agencies up with key organisations working in this area to progress some policy change. I'm sure I'll see some of you there. I wish we could invite you all. It'll be a small event, but I know many of you are from organisations that will be part of that event. Meanwhile, it just remains for me now to close off our hui with a karakia that basically sort of lifts off the tapu that we've had in our conversation and clears the path for us to return to our everyday lives feeling fulfilled and unified and blessed. So, kia ora koutou katoa. Ka whakairea te tapu, kia wātia ai te ara, kia tūriki whakataha ai, kia tūriki whakataha ai, hui e, taiki. Thanks again, everybody. Ka kite anō, and as I said, we will leave this window open for a few minutes so you can access all the information you need. Kia ora.